The kind of introduction, and this is the last session. It will be a multidisciplinary session on the locally advanced cholangiocarcinoma. I would like to have my co-chair, Dr. Lee, introduce the first session speakers.
Thank you, Professor Shira Rompong. Our first speaker is Professor Bruno Odisio. He is an associate professor in the Department of Radiology of MD Anderson Medical Center, and he is also director of clinical research in the MD Anderson Medical Center. His major interest is loco-regional therapy in the liver, especially liver tumor. Professor Odisio, please.
All right, good afternoon. It's a real pleasure to be here today. I appreciate the organizing committee for the invitation. So the title of my presentation is Intra-hepatic Cholangiocarcinoma. How can we choose among various liver-directed therapies? This will be pretty much talking about the role of interventional radiology and radiation therapy on that as well. Not a whole lot about surgery. It's not going here, sorry. All right, so those are my disclosures. This is just to illustrate the dimension of this disease in our institution. Comparing the number of new cases for biliary tract cancer, including all types of biliary tract cancer in MD Anderson from 2009 to 2015, we had a significant increase of number of patients refer new cases for us on this 6-year period. And likewise, we are also increasing the number of clinical trials that we have available for this particular patient population. NCCN guidelines talks about loco-regional therapies for resectable, unresectable patients with metastatic disease as well as post-resection status. Nevertheless, this is a category 2B by the NCCN guidelines, and the reason for that is the vast majority of the publications we have available so far are retrospective studies, and we need to improve on that. So when we're talking about loco-regional therapies for intrahepatic cholangiocarcinoma, it really depends where you practice. This is a survey from Japan where they evaluated the local regional therapies for patients with HCC intrahepatic cholangiocarcinoma. As you can see, ablation and chemoembolization are utilized in about 30% of the patients with HCC. Just a small minority of patients with intrahepatic cholangiocarcinoma receive this form of local regional therapies. This is pretty much because of the the lack of data supporting this analysis and the application of these local regional therapies, and also the advanced disease state that those patients usually present to. This is a paper published by our surgical oncology group and together with the radiation group with 362 patients who had local therapies. And we see that both patients who receive resection or radiation, they tend to have a best improved overall survival compared to patients who had either chemotherapy alone or best supportive care. They also performed time analysis, and both surgical resection has been improved along the time period study from 2007 to 15 compared to 1997 to 2006, and radiation as well. Radiation has improved in terms of the ability to increase disease-specific survival on those patients on those 2 time points that were analyzed. And when we take a look on the intrahepatic progression-free survival on those 2 time points as well, on the 1997 to 2006 and 2007 to 2015, we also show that surgery and radiation, they improve their ability to control the liver disease. And this is pretty much related to better selection, surgical technique and management on patients undergoing resection and on patients undergoing radiation, to the use of more accurate radiation therapy delivery that promotes a higher dose to the tumor, conformal radiation, and spares the normal liver from the deleterious effects associated with radiation. This study also showed that most of the patients who had resection radiation, they tend to have death not related to liver failure as compared to patients who had chemotherapy alone. So where interventional radiology stands on the treatment of patients with intrahepatic cholangiocarcinoma? Ablation literature doesn't help much at this point. I mean, there are new papers, but those are the most cited papers recently, where we can see that the number of patients are very limited on those studies, and the median overall survival goes as low as 10 months, as high as 38.5, and that is related pretty much to the patient selection and when you're applying this ablation therapy to those patients. So not much of a conclusion we can make on that. And local tumor progression, for instance, we compare to colorectal, which is the historical analysis, show that local progression at the ablated lesions is about 25%. We are getting very similar, with cholangiocarcinoma, but we have to learn more how to take care of those patients. So this is a combined analysis of our institution with University of Turin in Italy. 27 patients, 19 patients had post-resection recurrence, and we ablated 35 intrahepatic cholangiocarcinomas on those patients. Local tumor progression, the ablated lesions, about 28.5%. So it's still high. We see that the lesions that are less than 3 centimeters, they tend to have a local tumor progression rate of about 15%. So tumor size makes a big difference in ability to control those patients. Median overall survival from the time they ablate from the ablation, 31.6 months. Conventional TACE, same thing. Median overall survival from as low as 11 to 23 months. Different types of chemotherapeutic agents being utilized on those patients. More recent with the drug-eluting beads platform, we're seeing more and more people using irinotecan as the chemoembolic for those patients. But again, the survival is still, not that great and highly variable between the different groups that we are, seeing here. Y9 radioembolization, I think it has a good application for patients with cholangiocarcinoma. It really depends from the timing that you apply the Y90 therapy. Patients who are naive to systemic therapy, they tend to respond better, as this paper by the group from Bari in Italy show, Mosconi. One thing that we have learned recently is we have to use the dosimetry method in a way as effective as our colleagues from radiation therapy use. So we used to do a lot of the Y90s using the body surface area, and a lot of radiation used to be delivered to the normal liver, and the patients would have deleterious effects associated with that down the road. But now, today, we have to really use radiation on the setting of Y90 in a more tailored and personalized way for those patients. One thing I would like also to mention is the role of hepatic arterial infusion chemotherapy. We're not doing that on MD Anderson right now, but the group from Memorial Sloan Kettering, they've been using that, and they published this paper that they did on over 500 patients over 13 years, and median overall survival very good compared to systemic chemotherapy alone. They associated FUDR plus systemic chemotherapy and compared with systemic chemo alone, and they got a really nice response. So putting all together, the way we analyze the way, how we could deliver loco-regional therapies for those patients, it really depends on the tumor location, if it's peripheral or if it is central, and also the tumor vascularity, if they are hypovascular or if they are hypovascular. So if you have, for instance, a patient with a hypovascular lesion in a peripheral location, you can do radiation or ablation. That's the way we're doing on Anderson now. If it is a hypervascular tumor, you can offer pretty much any local-regional therapy for this patient. If it is a central location, hypovascular, transarterial therapies will not work, so you should do a radiation. If it is in a location that you cannot ablate safely, then you are left alone with radiation or transarterial therapies for those patients. I'm just going to talk a little bit about perspectives. We know that mutations are playing a big role on the management of those patients. for instance, RAS mutation occurs in up to 25% of those patients, and we know that patients with RAS mutation, they have a worse progression-free overall survival from the colorectal liver mets patient population. And we also show that patients with colorectal liver mets with mutational RAS, they tend to have a worse ability of ablation to control their local disease. The group from the Memorial Sloan Kettering showed that before, and we also show in a combined paper we did with the group from Italy. So maybe learning a little bit more about the mutations on intrahepatic cholangiocarcinoma will help us to tailor what kind of local regional therapy we should apply for those patients. Sequential therapy is something that we're doing a lot on MD Anderson, and the rationale behind is you add a synergistic effect on those patients, or you combine different local regional therapies because of a safety profile. So this patient, for instance, had a large cholangiocarcinoma on the right hepatic lobe, and did a radiation, had a really nice response to radiation, developed a new lesion on the right hepatic lobe. We did ablation on him, and he recurred on the ablated lesion in some of the radiated area, and a new lesion here as well. And we did a ablation and Y90 to the recurred lesion after radiation, and she's NED until last time we checked her last year. This is another patient that we did recently. He had a central lesion, did a right hepatectomy, recur with a lesion here on a very central aspect of the left hepatic lobe, so it's a difficult lesion to ablate it. Also had this is an intra-arterial CT hepatic arteriography showing how vascular the lesion was. We did IRE. Patient also had a lesion very close to the bile duct, so this could not be ablated despite of the small size, so we did a Y90 radial embolization of that lesion, as we can see here. And he also had some incidental lesions found during the CT hepatic arteriography that we ablated. We were able to show stability, no disease actually in this patient for 6 months. He underwent a liver transplant, and he had 5 tumors that we either ablated or we did Y90 with 100% necrosis, no tumor on the liver specimen. And you can on this here we can see the Y90 inside of one of the tumors with necrosis of the tumor. So conclusions: liver-directed therapies for intrahepatic cholangiocarcinoma, they improve the disease-free and intrahepatic recurrence-free survival based on the most of the retrospective data we have right now. It reduces the risk of tumor-related liver failure. We need prospective trials to learn more about the role of those therapies, and a multidisciplinary approach is absolutely key to manage those patients in the best way possible, and it depends on the local expertise where you're practicing. That's it. Thanks so much.
Thank you, Professor Odisio, for your nice talk about the loco-regional therapy for intrahepatic cholangiocarcinoma. And we have time constraint, however, we can allow for one question, please.
Just about Y90. Every randomized trial of Y90 has been negative. Yeah. Why do you think it works here?
Excellent question.
So the trials, the Surflox, for instance, for colorectal cancer, it came negative. And there are a few reasons for that. The main reason that the IR community thinks behind is that they use the body surface area instead of dosimetry, partition method analysis. I think differently from colorectal, cholangiocarcinoma tends to be hypervascular. And I think you need to document that on your diagnostic procedure with MAA before doing the actual Y90 delivery, as sort of like as a patient selection. So I think we're going to improve our patient selection, and we are in a point that we are learning more about the dosimetry on Y90 as a IR community, and I think we're going to apply that in a better way.